So before we start, I'd like to introduce myself. My name is Chris Kennedy, and I'm one of the DNP project faculty at Princeton Nursing University, and I'd like to welcome all of the online virtual audience, as well as your live audience, to this very important healthcare improvement project. And we'll, at the end, we'll pan around so that I can say hi and we can see all of you, but we'll do it at the end when, she's all got her presentation out of the way. And so I'd like to introduce Catherine Collins-Fulea. Kathy is the division head for midwifery for the Henry Ford Medical Group in Detroit, Michigan, where she leads a group of 23 midwives delivering at 2 hospitals. She completed her basic nursing and midwifery in England before returning to the USA to complete her bachelor and master's degrees. She has been a certified nurse midwife since 1981 in full clinical practice. She has been involved with a number of quality improvement projects over the years through her work with Henry Ford and has been active in the American College of Nurse Midwives, both locally and nationally. So, Kathy, I will turn it over to you.
Thank you. Oh, I'm unmuted. Okay, thank you. And thank you for letting me present the quality improvement project here at Grand Rounds. My project is improving timeliness of obstetrical triage throughput. And it's not moving. So I thought I had control, Chris. The slides aren't moving.
Down at the bottom, are you in presentation mode?
Where is that? Presentation, this one, presentation meeting, presentation and user.
IT might need to give you presenter, right?
Left. You're IT. They can give me presentation?
Right.
I know there should be something little down here. There's not. Oh, there. They gave me control. Okay. No? There we go. Okay, sorry. Okay, so here is the team. We started meeting in the spring of this year, and the team included nurses and residents and midwives and attending physicians, OB techs, IT people, administration, someone from reception, everyone that was a stakeholder in the triage project. And we did a fabulous job because everybody was engaged with the project. And I think that that's made the difference and made the significant outcomes that we've had. So OB triage is like an emergency department. There's very unpredictable volumes, and these impact the timely evaluation and treatment of patients. That then leads to long wait times and long lengths of stay. And that then leads to patient dissatisfaction, staff dissatisfaction, adverse clinical outcomes, and increased costs. We looked at some data before we started the project, and we found that the average wait time in our reception before you even get into triage was 26 minutes, that less than 70% of patients had vital signs taken within 15 minutes of arriving in triage, and our average triage length of stay was over 200 minutes. There was a negative correlation between patient satisfaction and length of stay, of course. It's not a surprise. And the team was only about 68% satisfied with the work they were doing in triage. We then did a causal analysis to look at what the causes were of the delays in triage. And I'm sorry, this is small for the people in the room here. Some of the big items that we talked about were not having lab results available in sufficient time, the nurses being too busy to get to the orders that we've written, because one nurse was trying to look after 5 patients, which is beyond the expectation that we have for nursing, that the providers were busy doing other things and didn't realize that there was a patient in triage that needed to be seen. Patients were in triage with really non-urgent complaints that didn't need to be there. So we do know there's a lot of literature that looks at nurse-driven orders in the emergency department. And nurse-driven orders are orders that nurses implement on their own based on a protocol before the patient is seen by a provider. And the nurse-driven orders, one of the biggest studies in the emergency department, looked at over 15,000 patients, and they were able to reduce the length of stay by 18%, or 52 minutes per patient. Standing orders is, the word is used interchangeably with nurse-driven orders in the literature, and there's not as much about nurse-driven orders or standing orders and OB triage, but there was one study by Haxton and Fahey that looked at over 500 women, and they were able to reduce the length of stay by 87 minutes by using standing orders. We also know there's other ways to try and decompress triage. One of them is having less patients coming into triage. And we know that patient decision tools help patients make better decisions and make better decisions about whether they should come to triage or not. Also, a study by DePauli looked at reasons for delays in triage, and she found that poor interdisciplinary communication caused some of the delays. Clicking on the slides instead of where I should. The Institutes of Medicine in 2001 put forward 6 aims for improving healthcare in America. And one of these aims was timely care, and that's the basis for this project. EMTALA also requires a timely medical screening exam for patients who present either to the emergency department or in active labor. And anyone who takes funding for Medicare, which we do, is responsible to comply with EMTALA. If you don't, there could be fines of up to $250,000 per incident. To improve the throughput, we need beds. We need beds to be able to see the patients. So either we increase our number of beds and staff to see the patients, or we decrease the number of patients, or we decrease the length of stay of patients who are already coming to see us. We know that the nurse-driven orders will help this by decreasing the evaluation to decision time, and the patient decision tool will help decrease some of the volume. And if we can improve our communication, we'll also be more efficient. So the aim of this quality improvement project was to decrease the length of stay for obstetrical patients in triage by 20% over an 8-week period by using the nurse-driven orders, improving our communication patterns, and through patient engagement. For those online, the Henry Ford Hospital here in Detroit, we have a 5-bed triage unit that sees approximately just over 6,700 patients per year. These are pregnant women over 20 weeks gestation of various ages and ethnicity, gestational age, gravity. During the time of this project ran, 28 different nurses rotated through triage, 12 midwives, 8 residents, and 5 OB techs. This was a rapid quality improvement cycle project that looked at 4 plan, do, study, act cycles of 2 weeks each cycle, and each cycle had interventions relating to staff engagement, patient engagement, nurse-driven orders, and compliance with the hypertension algorithm. These are, and again, I'm sorry, it's too small to see, so just trust me when I tell you, these are our wonderful interventions. The first cycle we implemented only when I was in triage, so we could test that we were on the right track with everything. After that, we went implementation 24/7. With team engagement, we looked at improving communications during the huddles. We developed a flag system for communicating when an order was ready to be filled in triage. And then we initiated clinical huddles when the patient had been in triage for 2 hours to see if that could improve the communication between the nurse and the provider to talk about what else do we need to do to move this patient forward with a decision. We developed a shared decision tool called When to Come to Triage to help patients decide whether they should come to triage or call the clinic. And then we developed a nurse-driven orders and a care algorithm for hypertensive patients based on the preeclampsia toolkit from the California Collaborative and the National Council for Patient Safety's Safety Bundle for Hypertension. So we did standardized chart. I did standardized chart audits twice a week. We had the patients that are the staff satisfaction tool that was given out every 2 weeks. Thank you to everyone who filled those out. I know that was a pain, especially when I come back time again. You just think you just did it. We plotted these results on run charts and then used that to evaluate the impact of the outcomes or the interventions on outcomes and to plan the interventions for the next cycle. Of note, patients who are in triage for C-section prep or cerclage prep or NSTs were excluded from the calculations of the length of stay. And these are the measures that were used, and you can all, I can send you the PowerPoint because I apologize again that this is very small on your screens here. The mean scores for patient satisfaction, staff satisfaction, length of stay, and compliance with the hypertension algorithm were used to measure. We also broke down the overall staff satisfaction into job classifications to see if any one job classification was adversely impacted by any of the outcomes or any of the interventions. The qualitative data from the surveys was converted into percentages and plotted on run charts. The quantitative data was obtained from the timestamps on the face sheets of when a patient shows up in labor or shows up at reception, when they're moved to a triage bed, and then when they're moved out of a triage bed. We used the timestamps for when an order was placed and who placed the order, and then when the orders were resulted, the time and frequency of blood pressures, and then an epic report to look at the overall length of stay. And then trends were noted on the run charts. So these are the results. And again, I'm sorry it's so small because they're really good and there's lots of stars up there. Our overall aim was to decrease length of stay by 20%, and we decreased by 23%. So we decreased by 46 minutes for the 654 patients that were included in the study. Team engagement, the return on the surveys from everyone was 56%, which is a really good actually return rate. Not that I didn't harass anybody to return them, but you still return them. And by the end of the fourth cycle, everyone's satisfaction, the overall satisfaction was up to 80%. The patient engagement tool was only used 72% of the time on the patients who are eligible. And we'll talk in a minute about why this happened. But for the 152 patients who actually received the tool, they were very satisfied with it. Nurse-driven orders were used 91% of the time on eligible patients. This was 59 patients. And again, we did not decrease the length of stay by as much time as I had hoped there. We only decreased by 9%. And we'll talk again about why that was. We were 100% compliant with the hypertension algorithms, and the balancing measures showed that all of the different classifications increased their job satisfaction. Wait a minute, too far forward. Okay, so this graph looks at, in teal, is the overall length of stay for patients. That's where we decreased by 23%. And in green is the length of stay for patients who had the nurse-driven orders, the hypertensive patients. And you can see several outliers, large outliers, which affected the overall length of stay. And these were times where the provider felt the patient just wasn't ready to leave. We just needed to watch their blood pressure a little more, or wanted to watch something a little bit more before we decided whether we should admit them or send them home. There was also a time that there was no beds on the unit, just like last week. And we obviously can't move patients out, patient waiting for ultrasound, but they were reasons other than not having lab results available. This is the team engagement, and we increased from 68% up to 80%. Of note, this green here is the resident team engagement. And the first week, or the first two cycles, we steadily increased team engagement. And then it all of a sudden took this huge dive because we had brand new interns on the unit. They weren't familiar with obstetrics. They weren't familiar with the unit. They weren't familiar with the people. They weren't familiar with the protocols. Don't point to anyone. And of course, they are not going to be happy with what's going on. But I think it's a testament to some of the improvements that we did, because by the end, they were up to 80%. And you guys didn't even realize how happy you were. The other ones basically had a steady increase. This is a patient engagement tool, the first version, the second version, that helped patients to decide whether they should come to triage or go to the clinic. And the utilization, again, was lower than expected because of this big dip here. And this was, I wasn't on the unit that much that week. I actually took a vacation week. And I came in to just audit the charts instead of prodding people. And the nurses thought that we weren't using the satisfaction survey for patients anymore. They said they were using the patient decision tool, and they all really liked the decision tool. But the satisfaction piece was what I used as a proxy for the fact that they gave them the tool to use. So we were way down, but when we adjusted where we were putting the tools, we were right back up to 80%. So I think that was just like a little outlier. This is the hypertension algorithm, where all patients have vital signs taken within 15 minutes of arriving in triage. Patients who have an elevated blood pressure over 140/90, then have their blood pressure cycled every 15 minutes and have lab work sent automatically. This would be CBC, LDH, a biochem profile, and urine for protein and creatinine. Any patients who had blood pressure in a severe range, they had those things set, but an immediate call went to a provider to come immediately to see them in triage. And we were 100% compliant with the hypertension algorithm. So we were giving patients the right care at the right time, which is really good. So some of the key findings then, just to summarize in case you fell asleep here. The overall length of stay, we decreased by 46% for all patients. That's a big win. The hypertension cohort length of stay only decreased by 17%, or 17 minutes, sorry. Staff satisfaction increased 12%. All job classifications increased, but the OB techs who maintained. The patient decision tool was well received. We were 100% compliant with the hypertension algorithm, and we decreased the mean time from arrival to test results by 49 minutes. So that also gets the results in the hands of the provider sooner. Some of the strengths of the project are that we had great team engagement. Everybody wanted to make improvements. Everybody was contributing. Everybody was talking in the huddles. And I think that's because we do have a culture of continuous improvement on the unit, and we always collaborate. So we're used to talking to each other. There's minimal cost other than printing some of the flyers. And this gives more autonomy to the nurse in triage, as well as putting more data in the hands of the provider at the time they come to do the evaluation. So even though we didn't appreciate the decrease in length of stay that was talked about in the literature when you use the nurse-driven order, we still were able to decrease the length of stay overall. And it seems that the hypertension cohort that had the nurse-driven orders, their length of stay was probably more reliant on provider preference than on not having test results in someone's hands. And our focus on communication and being able to be very conscious of the overall length of stay and trying to move people through faster really had a strong influence because we were talking about it and focusing. The surveys and the huddles, I think, really helped the staff have a voice and talk about some of the issues that they thought needed some improvement. The patient decision tool has a great potential to help us decrease unnecessary patients coming through triage. And as far as limitations, the generalizability will depend on other people's staffing models and the preference of their providers, as well as the staff engagement. If people are engaged, they're not going to have the same successes. So in conclusion, we made a significant impact on triage throughput. Less crowding decreased the risk of error, improves satisfaction, and decreases workload for everyone. The only thing we need for sustainability really is a willingness to facilitate the timely discharge, really having that in the front of our minds. And as far as next steps, we have a formal policy for nurse-driven orders for hypertension as well as for nausea and vomiting. We added that in. Moving through the hierarchy right now, it will be a tier 1 policy for all 5 hospitals. And Epic is working on the order set right now so that we can easily access that. The When to Come to Triage tool was transitioned to the SRT team that's looking at outpatient education. We need to continue our focus on communication, talking to each other, and then we need to spread this to the other system hospitals. It was presented, I presented at the System Perinatal Collaborative, and now we're really just waiting for the tier 1 policy. So here's the references. I know you're going to all look up everything. And I have a couple of questions, some feedback I need from you guys, really, as far as what you think about how we can hardwire some of the improved communication patterns or what other strategies for communication. What do you think about the utilization of those clinical huddles? I personally really like them, but I don't know how many people really use them and how much they want to use them. And then should we have a time limit on triage? And if so, why or why not? You can all speak at the same time if you wish. We need some feedback.
So I have just a quick question about the timeliness of discharge. What do you think are some of the factors for why that may be? Do you think a lot of it has to do with maybe transitioning from one care provider to the next? Is it happening mostly then when you have a new set of team coming in and then they're signing out and that may delay?
That happened, yeah. That
That
happened a little bit, that at the time that we hand over a board report at 7 o'clock at night, the triage midwife leaves and we give board report and then we do collaborative rounds. So it can be at least an hour or more before anybody wants to pay attention to triage. And if someone just came into triage before that, that can definitely happen. But it was more that providers said, I don't think she needs admitted. I don't think we need to admit her, but I'm just not sure yet. I just need a little more time to find out.
Thank you, Kathy. That was excellent. And these types of studies provided a lot of value to our patients from an efficiency standpoint, cost perspective. So it was really good, and I think this can be very powerful. I think it would be nice, looking forward to answer Malik's question, is actually start figuring out what is the cause of the delay, which of course requires man work to put, why is the delay there? Because sometimes we make these, and your study, by the way, makes me more conscious of how long the patient's in triage. Because a lot of times the senior staff has no idea how long. We just know when you come talk to us and we don't feel like we have enough blood pressures, and then sometimes we don't consciously say, well, you know what, I don't want to put her in observation. I don't want to take her out of triage because we only have 3 beds left. And I'd rather keep her in triage than put her on labor and delivery and take up that bed, only to have her leave an hour later. And so, but this whole concept of communicating and huddling about it makes a lot of sense because it puts it to our forefront. You know what, this lady's been in triage 2 hours now. Does she need to be there an extra hour? Can she go home? Let me prioritize her with all the other things I have to prioritize to get it done. And then if we had consistent coverage in our triage with one particular provider at night, like we do in the day, maybe that would help with throughput. So it's studies like this that can help our cost perspective when we justify when we need to hire extra people. So I appreciated an excellent job. And I thought it's a mic drop for you, by the way.
Oh, is it a mic drop? Okay, because I thought you were just about to say we can hire midwives 24/7 for triage. No, I think Dr. Bucher slipped out. Yeah. But Dr. Munkar is here. He's even higher up. He could give us.
Not about the money, it's about the money.
Yeah.
But it also points out what you said, Kathy, about the nursing, that there's one nurse for 5 people and usually 5 waiting. And so that nurse doesn't have an ability to go out necessarily always to triage. The charge nurse does help. But these are usually, and it's not like 5 people with a sore throat. I mean, there can be critical blood pressures, preterm labor, preterm contractions, cerclages. And to have, I mean, when they built that triage, they told us 2 nurses. And we've just never been there. And that is a critical point for the unit for the throughput.
You noticed Alyssa slipped out just before you said that.
Very aware.
Yeah, I know. Cheryl, did you?
Oh, yes. Two comments, and it's to tag on what Dr. Lee just mentioned about huddles and timing. Maybe I think huddles are fantastic, and I think we underutilize huddles not only related to triage, but in general when things are getting really busy. So I think intermittent huddles along the same line as with your project, and then when maybe we can incorporate from a timing perspective, as Dr. Lee said, the provider may not be aware as to the length of time that person is in triage. So maybe in the conversation when the nurse is calling the provider, Dr. Lee, Ms. Jones has been here for 60 minutes now, and then start the question. So maybe including the time frame in that conversation so that the providers have a frame of reference of, I'm calling about this and she has been here for X amount
That's a
of
great
time.
idea.
And maybe even put it somewhere on that patient's, on the triage log or somewhere so that it's visible, but it's also embedded in the conversation and we make that a routine.
It makes you wonder if Epic could add a column. If Epic can add a column where the time, like we do with patients who are in observation, a column that says how long they've been there.
Right.
I don't know if they can't. That would be really helpful.
Then if you can have a visual and then, but also embedded in the conversation because someone may not be at their computer.
Yeah.
But then you can, Dr. Lee, the patient has been here for an hour and a half. And,
Yeah.
and this has happened, but that time frame is then part of the conversation. And then the huddling as well will be, is good to be consistent with that as well, because you can certainly take care of a lot of problems when all of the people who are there to help solve the problem know about the problem and are having a conversation together.
And then letting the patient know, because sometimes patients are tolerable about wait times if they think that
Somebody's assessing their situation, but if they've been there 2 hours and they have no idea that we've been discussing your case regularly and our practice style is every 60 minutes we have, then their expectations are a little bit more aligned with their wait time, and maybe they would not be satisfied even if there's a longer wait than we would want.
Good point. Any other thoughts or comments? Dr. Paquette, did you, I'm sorry, Auntie Clemmy, my Aunt Clemmy came. Aunt Clemmy is a PhD nurse also. So.
I'm very proud of you, Kathy, Dr. Kathy. I'm coming in without a real solid OB background, but I could say that Henry Ford Hospital could offer more time for your presentation. And also, the overheads that were too small, we needed to at our, but I think the triage idea in the huddle is great. I think it would go well in all the units and the huddle. Good job.
Thank you. I gotta.
You know, you can present this again if you want to stay
yeah,
longer.
that's right.
We can make room for you in our January. Just let us know.
I gotta say that it is not Henry Ford that restricted the time. It is Frontier Nursing University that said it had to be in this amount of time. And I had to finish speaking within 20 minutes so that you all could talk too. So it was very, very prescribed. And see, Chris is back on the line now, and he needs to.
I want to see Auntie Clem.
You want to see Auntie Clem?
Yeah, we say after that.
Okay. So I don't want to make anybody dizzy here.
Hi, everybody.
But you wave Auntie Clemmy.
Hi.
So, as I do this, yeah, everybody can wave.
Wow, you had a great turnout.
Okay.
Well,
1 second, Chris. Dr. Paquette has one more thing to add.
okay.
And I really do appreciate from the resident perspective, speaking Jacqueline and Russell Dominic and stationary hypertension. Obviously, they're two of the big places where patients sit in triage for a long time. So everyone else's comments were great, and I will miss you, but President-elect Macy,
Thank you. Okay, Chris.
All right. Well, I would like to first congratulate the future Dr. Catherine Collins-Fulea, who, upon completion of all didactic and clinical requirements of Frontier Nursing University's Doctor of Nursing Practice program, will have demonstrated mastery of the DNP essentials as defined by the American Association of Colleges in Nursing. So now I'll release the online community, and you can continue to celebrate there. And congratulations on your retirement and a great project.
Thank you. Bye, everybody. Woohoo! We're done because we have another presentation, I know.